Hello and welcome to Single Payer Radio. I'm Paul Hoppy, broadcasting from the Hayburn Building in Louisville on the WFMP 106.5 Forward Radio Community Network, where news, information, and entertainment is available 24 hours a day, 7 days a week. The views and opinions expressed on our show are those of the speakers and not the station. Single Payer Radio is a project of Kentuckians for Single Payer Health Care in conjunction with Physicians for a National Health Program through its Kentucky chapter. We produce this program because we believe health care is a human right. We advocate for a national, not-for-profit, publicly funded single-payer health care system, commonly referred to as Enhanced Medicare for All, covering dental, vision, hearing, prescriptions, and long-term care, covering everyone starting at birth. Catch our program at 2 p.m. Monday, 7 a.m. Tuesday, and 11 a.m. on Wednesday. We also stream our show on SoundCloud so you can listen anytime. This radio station relies on volunteers like me and your ideas and donations to keep us on the air. Today, Doctors Mike Flynn and Gene Shively join me as co-hosts with a special guest. So let's get started. Dr. Flynn?
Yeah, this is Michael Flynn, a retired surgical oncologist from University of Louisville Surgery Department. Let me begin with the usual disclaimer. Many comments that I make represent my personal views and do not represent the views of the Department of Surgery or the University of Louisville. Gene?
This is Eugene Shively. I'm a retired rural surgeon in Campbellsville, Kentucky at Taylor Regional Hospital. What I say reflects my own opinions and not that of Taylor Regional Hospital, nor the University of Louisville, nor the Department of Surgery.
Our topic today involves mental health issues related to drug use and addiction. And we have a special guest that I will introduce in just a moment who has some special skills in this area. And it was we're gratefully willing to come on and talk with us about this important topic. Our special guest is Christopher Stewart. He is Associate Professor in the Department of Psychiatry at the University of Louisville. He got his medical degree, did a psychiatry residency, and a fellowship in addiction psychiatry at the University of Louisville. And Chris, thank you for coming on and talking about this important subject. As time goes on, the issues of mental health with all the stuff that's going on in the internet and drugs and addiction has become more and more and more important. So we're very grateful you're willing to come on and talk about this. As we have done with our guests in the past, we're going to give you an opportunity to make whatever comments you'd like to make for as long as you'd like to make them, and then Gene will begin with the conversation. So, Chris, the floor is yours.
Thanks for having me. Thanks, Mike, for having me on. It's a really honor and privilege to be here, and really appreciate the mission and the spirit of this radio station and shows like this. So again, thank you for having me. I'm an addiction psychiatrist, and I am at the University of Louisville Department of Psychiatry, where I've been for many years. I took a brief break to do private psychiatry in Chicago for about 4 years, but came back. And so I've been with the U of L Department of Psychiatry since I was a resident. And so I've been in this community a long time. And I worked in the field of addiction for most of my career. And I do some general psychiatry, but mostly outpatient addiction treatment and involved in all levels of addiction treatment care. So to me, the crisis has been here with the alcohol, cocaine, and then we went into the opioid crisis, but I felt like I've had a front row seat for much of that. And in our state, Kentucky, we've been particularly affected by the opiate addiction that has affected the whole world and been so devastating. I think people are a lot more educated about addiction than they used to be, and that's a good thing. And I think people recognize more how important it is to seek medical care for substance use disorders or addiction, and that I appreciate. I think we can still do better. We still have a long way to go. We still have a lot of bad attitudes and bad ideas. You know, the biggest thing you combat in addiction is that it's some kind of moral failure or it's stigmatized by our society. And the idea that has been very harmful to the cause of getting people help and intervening earlier. And with any disease, and addiction is a disease, you want to intervene as early as possible. So it's really important to recognize that addiction is a disease, and it really responds like other diseases to a medical approach. And that includes then not making as much, not judging it, and not going along with stigmatized ideas or beliefs about it. The other thing is addiction's a disease that really affects the brain. With drug and alcohol use and addiction, we really focus a lot. It involves the whole body, but we also really focus on the brain idea of what happens to people when they become addicted to a substance. And we know that the earlier you get exposed to a drug, we know for a fact that makes you more likely to become addicted to it. And so we have a lot of knowledge about what goes on neurobiologically with drugs and alcohol, and there's been a lot of advances with medications. And having said that, I'll finish with this. And all that's exciting. We still are very, very humbled by this epidemic of addiction. And it's a disease of isolation, and it responds to still traditional types of therapies like counseling and individual and group therapy. And I've maintained a group psychotherapy practice because I don't see as many advances as we've made. I don't see those delivering us out of a lot of the basic ideas that have been here for almost 100 years about the treatment of addiction in the context of community and society, and learning how to socialize people again and heal people through the traditional ways. So I just wanted to say that.
Okay.
That's all I got.
Jen, you want to begin?
Yes, sir. I was interested if you treat a person's mental problems or psychiatric problems, does it help in treating their addiction? And how close related are psychiatric problems and addiction?
Yeah, it's a great question, and it's been a big part of the discussion in the field of addiction for a long time. The way I see this is that addiction's a mental illness, and I haven't really seen very many patients where they only had addiction and that was the problem. Most patients have some other type of mental health issue or mental illness, and we know that treating both is very important for recovery. If you neglect one or the other, you're not going to get a good result. So just like with any illnesses, they can affect each other. But the idea that they're even separate sometimes is, to me, it's complicated because this is probably anticipating a question, but the most common mental health issue that I deal with in my practice with patients who have substance use disorders or addiction is what I identify as post-traumatic stress disorder or trauma-related illness. And you can diagnose PTSD in the early stages of recovery from addiction or even an active drug addiction, and you can accurately diagnose that. And it is known that you must, if you want to get good outcomes, you have to address that as part of the treatment for the addiction. And that goes for any real mental illness, depression, mood disorder, psychotic disorders such as schizophrenia or bipolar disorder that get a lot of attention. You have to treat those while treating the addiction at the same time. It's not always easy to do.
Well, how do you treat the post-traumatic stress disorder? I've heard various things, like talking about it, communicating about it, and then obviously I've seen patients who are on drugs for that. How do you go about treating that in people who are addicted?
So you have to be careful when you treat PTSD in people who are in early recovery, because if you're the old school way we used to talk about was debriefing patients and having them talk about their experiences, and we would debrief them in great detail. And what we were doing a lot of times was re-traumatizing people who were trying to stay sober or get clean, and they would go back and relapse. And that's been well recognized now for some time, that treating PTSD has to be done carefully. I like to treat people for nightmares, symptoms of anxiety, and intrusive thoughts with medication. I often tell patients, I don't need for you to tell me the details of what's happened to you to help you deal with the symptoms right now while you're in early recovery. But as part of the process of treating someone for PTSD, it does involve sometimes doing some work around just talking about what happened, but not always. More and more therapies are geared towards dealing with the symptoms, dealing with the process of PTSD and learning how to cope with it without necessarily having to go relive past traumas. And somebody who works with trauma and addiction, it needs to have experience really in both. I don't think you can do this without having some experience in both addiction and trauma to work in either one.
Now, Chris, let me ask you a question about PTSD. Now, I spent 20 years in the Navy, spent some time in Vietnam,
Yeah.
and was around people in the military who had that type of related trauma.
Uh-huh.
So my question is, what other traumas do you? You mentioned some of them. You may have partly answered the question already, but just for our from the standpoint of our listeners' understanding, what actually involves PTSD in a civilian population, aside from the issues that some military people get into for whatever reason.
Yeah, trauma has really become a whole field that has expanded and become more broad and broadly accepted and talked about than back in the time where it initially was a diagnosis for people who had been in combat. And now we really recognize trauma in everyday life, experiences that people have with diseases. For example, I'll just give an example. Having cancer is traumatizing to patients, and the treatments they go through and what they go through with having cancer causes often a form of PTSD, or what we call medical PTSD. But developmental trauma is talked an awful lot about these days with regard to addiction. And when you talk to patients, they often will identify some what we call trauma from early childhood. Not everybody meets all the full criteria for PTSD. I want to say that I see, but everybody typically has what are called high ACE scores, or adverse childhood experiences, which is a study we could talk about. But the ACE study was really important in establishing that adverse childhood experiences predict morbidity and mortality in medical illness and psychiatric illness. And essentially, it's sort of a stress induces serious medical and psychiatric disease kind of study that, to me we still haven't totally completely come to terms with for its ramifications. But that to me is about PTSD. I see that in the lens of PTSD, that anything can be traumatizing, and an event that's traumatic is a shocking event, or it causes a traumatic response in a person. That doesn't cause PTSD. Everybody has had traumatic events in their life. You don't get through life without having something. But PTSD is when essentially you keep reliving the experience in a variety of ways, either through just physiological responses, never feeling safe, or really literally re-experiencing in memories, reliving the event, having nightmares about it. And that can be extremely difficult and be disabling sometimes. And there's a whole range of experiences people have. So you can give medicines for the symptoms. So, like for example, in early treatment, people get sober, if they're going into detox, or they're even early treatment with medications, they'll begin to have symptoms of PTSD that emerge, and they'll have nightmares sometimes. And we can give medicines a lot of times that are not addictive, that can help with the nightmares. And that greatly helps them participate in their addiction treatment programming and aspects of addiction treatment that they need to. That's the most common way I often deal with PTSD. And it often doesn't get identified. It's often missed, and it's not hard to identify. I mean, it's one of the few diagnoses, like I said, it can be diagnosed when people are actively using drugs and alcohol. A lot of psychiatric illness is mimicked by drugs. Somebody's depressed and who's drinking a lot of alcohol, has an alcohol problem. They may have depression, but that depression may go away when they stop drinking. With PTSD, it's not like that. It's going to be there. You can rely. It's pretty reliable when it shows up.
So how much, one more PTSD question, and then we can
Sure.
move on to something else. How much of this is involves the internet, especially in young people? The issue of bullying, sexual activities and things like that go on the internet seems to be I never grew up with that. Neither did I think any of us. Paul, Gene, or you had grew up with the internet the way people are growing up. Adolescents are growing up with it today.
So we have an expert in our community. You might maybe get him to talk on here on screen addiction in young people, and I'll tell you his name if you want me to mention it later. But that would be a good person to talk to about particularly the phenomenon of the internet and the technology.
Yes, that would be
screen time on young people. That's a whole separate subject to me. And screen addiction. I'll say this I think that traumatic experiences from bullying and certainly it's been facilitated by social media, but I think social traumas from early childhood have been around for a long time and have had an impact. And I think we just are maybe talking more about the impact that's had in people's lives. But for example, you mentioned bullying. I mean, that can be devastating for people into their adulthood. And I don't think always that recognized as having, long-term impacts on people's mental health into their adulthood. But I've talked to a number of patients over the years, and that's been a substantial part of their story. And I just think we have to, think about it more deeply and ask questions and listen. And that's how we kind of discover some of these things. But I think they were kind of around before. I do think it's a new situation with social media and screens. I mean, and that's affecting our brains and it's changing who we are. There's no doubt about it.
Let me ask one more question about PTSD. I know a person who literally hates her father because of traumas to childhood. And now, should that person try to establish a relationship with him and forgiveness, or is it better to just try to stay away and not approach that issue?
That's a tough one. It's going to be dependent on the situation. I'll say this: you can heal from PTSD when you are not safe. So if you're actively using drugs and you have PTSD symptoms, I'll say this much too. People can be traumatized, can have the symptoms of PTSD, but it's when they persist after 6 months that we say this is PTSD. A lot of times after a bad accident or some incident, people will have symptoms, and that's normal. It's when it persists after a long period of time. Somebody who has a complicated relationship or had an abusive parent, that's complicated. There's developmental trauma, but there's also issues with attachment trauma, and that's going to be more complex. And if you're in a relationship with somebody who's hurting you, well, you're not really safe. And until you're able to establish safety, then you really couldn't deal with that like you wouldn't. Then it would make so that might be something down the road where you work that out. But if you had somebody who, well, let's say the danger had passed and people were trying to repair a relationship, which is a good thing. That can be a very useful thing to do as long as it's safe. And that's the $1 million question, right? And again, if you're using drugs, by definition, you're not safe. If you don't have a safe place to live, if you're not in an environment where you're safe, or where you're being, harassed, or you have to worry about, if you're worried about, for example, poverty is not a safe condition. If you're worried about where your next meal is coming from, you have food or financial insecurity, that's not safety. And so that becomes very difficult to heal from PTSD. And so, yeah, a lot of PTSD symptoms people have normalized because they're not in an environment where they're going to be able to really resolve that. And when you're in survival mode. Okay. So I guess what I'd say to your friend is, if you have to be safe with yourself, you have to have good boundaries and be able to enforce your boundaries and make sure that you're going to be safe. And that means emotionally and physically. that can be daunting if you have some, so it might not be possible to repair with somebody like that. I don't know.
Well, let me
And
ask you a fundamental question about
Yeah.
drug use and mental health. And again, you may have answered this question in your opening remarks, but just to clarify this for our listeners. So how much of drug use and addiction is related to mental health issues as opposed to somebody who has an injury, takes a pain medication, and gets hooked? I'm partly asking that because I'm not sure what the answer to that is either.
Yeah, well,
So
we know a lot of people who took pain medication, got hooked, who had started out with, they were injured. They had an injury. Maybe they were a high school student who got injured and had to have orthopedic surgery. There's a number of these patients who started being prescribed opioids and it developed into a problem. And sometimes that had to do with, the way they were, the access they had to opioids for the period of time. Like, if you give people high doses of opioids for long periods of time, most of those patients are going to become physiologically dependent, and a lot of them can become addicted to opioids. We know that now. There was a time where that was controversial, which sounds kind of silly, but it was. And so I don't know if I think about it in like that patient who got addicted because of being prescribed opioids by their doctor for pain. They were probably vulnerable, but that's tricky too, because that's been used to stigmatize patients as well. And I don't want to stigmatize anybody today. But people do have vulnerabilities to addiction. People have genetic vulnerabilities to addiction that run in families. And people have, I think, psychological vulnerabilities based on their experiences. And that includes trauma and adverse childhood experiences. So the higher your ACE score, the more likely you're to develop either a mental illness, addiction, and medical problems can be worse. And an adverse childhood experience is something that happens before the age of 18, and typically involves there's a list. There's 10 items, and you go through it. But they're in things like, did somebody in the home have a severe mental illness? Was was there violence in the home? Was there active substance use? Did anybody anybody in the home that you were in before the age of 18 go to prison, which is a real traumatic event? Those things are what are called ACEs. And if you have a bunch of those, the more you do, it's a linear line. You have more likelihood of having problems with things like not just addiction, but depression and medical problems. So I know poverty is definitely on there. As I think I consider poverty an ACE, growing up and adds to vulnerability. But I think we also need to be careful we don't stigmatize, because we have to talk about resilience too, that patients have. But again, those things do make patients more vulnerable. So mental illness does make you more vulnerable to addiction, and the earlier you get exposed to substances is bad. It increases the risk of developing problems later on. But it's kind of it's all at the same time, all at once, the way I think about it.
You talked about poverty. If you in the news right now, the Congress is talking about the ACA, but you don't hear much talk about the Medicaid and restoring that. We're only about 3 weeks off of the first of the year, and it could have a devastating effect if they don't restore Medicaid in Kentucky. How do you think that will affect the treatment of mental illness and addiction in Kentucky?
I've been here. I have an interesting. I think I have an interesting response to that. That may be a little different than what. It's going to be similar, but a little. I want to add a few more things that people don't always think about, maybe, or realize. So in 2020, we started getting $1 billion a year through SAMHSA to address the opioid epidemic, and that was the Trump administration who provided that funding, unprecedented levels of funding for the opioid epidemic. And I just want to mention that because it changed, in my experience, it was a real change in in the level we were addressing the opioid epidemic. And that was under the Trump administration. It was also at the time we had expanded access to Medicaid, which is extremely important. And because of that, we have made major progress in dealing with the opioid epidemic. We still have a long way to go. We have reduced overdose death. We've made things more accessible. But to me, this represents the same administration and the same government cutting Medicaid, reducing access, is sort of taking your own initiatives that you started and made progress with. I mean, and really helped a lot of people, and kind of shooting yourself in the foot. So I hope that this changes. But this there's a lot of criticism at the current administration and the powers, but they're also the same administration that made a huge impact in a positive way in the opiate epidemic. And so I say that in the hopes that the people who are part of that will say, yeah, we did do something really good. Why do we want to stop what we were doing? And so reducing access to people, because we really rely on Medicaid for a lot of our patients to have access to treatment. So if a lot of patients lose access, that is going to be devastating. It's going to devastate the infrastructure of addiction treatment, because when you don't have the ability to get reimbursement for services, then the systems that provide those services, they naturally decline or close or become less available. Then when you need them, they're not there, and you got to spend a lot of money to put them back together again. So it's very destructive to put it out there. Now, the problem that I'm being told from people is there's a lot of waste and fraud going on, and that's in the addiction treatment industry, and that's one of the rationales behind wanting to cut back on that. I don't know about that. I think again, what I see at university, at where we're at, was people have access that didn't have access before, and I see an improvement in our results with addiction treatment, and people generally are more interested and more available for treatment as a result of all of the efforts. And it's been an enormous effort, an enormous amount of funding that's gone to help us with this problem. So I'm very concerned about that. And I know there's a vote in Congress coming up. I'm so crossing my fingers that maybe something happens positively there, but I'm not terribly optimistic. But I think, people need to demand that, and the ACA is not I think it's not a perfect, it had problems too. So just because we go back to the ACA doesn't mean we're going to solve all our problems around coverage. But we made major advances that we will lose if we cut access to Medicaid for a lot of
Now,
patients.
we had Jason Smith on a while back, and he told us that with the expansion of Medicaid under the first Governor Beshear, the non-paying patients at U of L Hospital went from 20% down to 5%. Now, unfortunately, the ideological geniuses in the national legislature are justifying this in order to pay for tax cuts for the billionaires and the corporations that are supporting them. So we'll see what happens. Let me ask you another kind of more fundamental question again. Some mental health conditions are more likely to involve, some mental health conditions more likely to involve drug use and addiction than others? Because, it's just because you've got some anxiety, does that mean, you're going to be more likely to use drugs than somebody who's
Sure.
bipolar or schizophrenic?
Everybody thinks about bipolar disorder and addiction, and that's not the top one, but it's definitely, if you have bipolar disorder, you're more likely to have a substance use problem, and you're more likely to use substances when you're in a manic state. But that also diagnosis gets mislabeled. People get that diagnosis who often don't have it. And a lot of people who have the diagnosis don't get properly identified. It's a tough one. And when you're in settings, you see that diagnosis an awful lot. And it's tough because somebody on stimulants or other drugs can mimic the symptoms of bipolar. So that one's one that we continue to but you really want to identify it when you can, because if somebody has both addiction and bipolar, the outcomes are not as good as when they just have bipolar disorder, and you really do have to address both. What I think is so that's really important. But also what's important is social anxiety disorder and alcoholism. People who have social anxiety are at greater risk of developing alcohol use disorders, and I think we see that a lot. I think we see people using alcohol as sort of safety, as a safety behavior, and many patients who developed alcohol problems had what we identified as social anxiety disorder, and that made them more vulnerable to developing alcohol use disorder. Also, everybody talks about ADHD, and the research is important there, and shown that if you have early intervention for ADHD prior to adolescence, you reduce the risk of that patient developing a substance use disorder. And patients who are not treated for ADHD are more likely to develop a substance use disorder later as adults or adolescents. So that's a disorder that's important to intervene on. I will say, once someone has ADHD and is using substances or has an addiction, then the research on the impact of the substance use and the treatment is not as clear. But we still think that you probably need to treat both and address both, but it's more complicated. And depression, is definitely a risk factor for drugs, and so is anxiety, right? And I know we already talked about PTSD, which is really an anxiety disorder. It kind of belongs with the other anxiety disorders in a lot of ways.
Now, let me ask you a similar question in a different way.
Okay.
So are certain mental health conditions more likely to respond to treatment and stop drug use than others? So this is just the same issue about addiction and drug use and the frequency, but then the question is, do some respond better to treatment than others?
Who responds to treatment and who doesn't?
Are you asking me? Or
No, that's the question I'm hearing. You're saying who responds and who doesn't, right?
Well,
So
related to mental health issues. Yes.
Yeah. So having more severe mental illness is a predictor of a poorer response in general to treatment. So it's not good to have additional illness, period. Patients who do better with substance use are not as the ones that they do better and either quit on their own or do better in treatment. A lot of times are patients who don't have as many problems and don't have as many other problems. So the sicker you are, you don't do as well typically. Now, who responds? There's probably some more. We have more information about who might respond to certain medications, but I don't think that's what you were asking me. I will say this. Let me say this about that. It raises something I wanted to remember to talk about, which is, let's say you have a mental illness and you treat it, and the idea a lot of times patients would have that would drive us addiction psychiatrists crazy would be to say, well, I drink because I'm depressed, and if you just would treat my depression, doc, you don't have to bother me about drinking, and I can drink the way I want to. And a lot of times sometimes every now and then that might be the case, but most of the time it would be, no, you have to quit drinking, and it's like, well, you don't want me to have any fun in life. It's like, no, I want you to be, I want you to feel better. But, you're basically taking in a depressant while you're depressed. And I might treat you for depression. I might give you medicine or do therapy, but also we really need you to quit drinking. And that's sort of how I think about that in terms of if people are going to get better, they often have to be treated for both. You can't just treat one and then, the other one goes away because you're treating the underlying cause. Like, people use the phrase that really I find annoying, but it's not. It's a useful phrase called self-medication, and it's true. People do that. There's research to indicate people who pick a certain drug, there sometimes is a reason they're using a certain drug, and so because of that, if you want to address that underlying reason, you might help them abstain more.
Well, Talking about self-medication, what about marijuana? We've recently passed a law in Kentucky on medical marijuana. What I've read is there's no clear scientific evidence that medical marijuana works, and there's some question. And even Congress is thinking about changing some of the laws. So, what's your opinion about marijuana as an addictive drug, and does it lead to other addiction? And should we be pushing medical marijuana right now?
Okay, well, so marijuana. The big problem with marijuana and saying that it is medication is that the research, in my opinion, does not support that. We don't have good research on marijuana as medication, partly because of the way it's classified by the DEA. And it's classified at the same level as heroin and cocaine and other drugs, where there's no medical value, at least according to the DEA, and high risk of harm. And I think that is probably a problem. And I think it is a problem where the research that we do on marijuana in the United States now that we can do is grown in Mississippi and is at a potency of about 3% THC. So we can't study the actual marijuana that's being used by everybody because it is a much higher potency, and we can't have reliable research to guide us on what would be good medical use of marijuana. How could we establish, standardized things like dosing and guidelines and all those kind of things that we would do for any other medical treatment. This is a treatment that's been pushed as a sort of a political movement. And I understand to a degree why, because of the DEA classification makes it very difficult. A lot of people feel that it shouldn't be criminalized, and I think it's been exploited to violate people their autonomy and arrest people. And again, I think that's a separate problem than decriminalization is separate from saying it's medical. I think I would rather just, from a doctor standpoint, from telling people, yeah, this is good for PTSD, for example. A lot of people say it helps with PTSD. I'm not saying it doesn't. I'm saying we don't have good research to really support that. Not the research that I've looked at.
Well, let me make a comment about marijuana and get you to respond to it.
Yeah.
Now, I smoked marijuana once when I was a resident and fell asleep, and I've never gone near it again, so I'm not an advocate
That
for
wasn't
it.
the same. That's not the marijuana that they have nowadays, Mike.
I don't know what it was, but anyhow.
That was very low potency marijuana.
Yeah,
So the stuff now is a higher potency, close to 20% THC, which is Delta 9 THC is the compound. It is addictive if you use marijuana, and raising the potency makes it more addictive.
Well, that wasn't my comment.
Go ahead.
I just admit that as an opening statement.
Okay.
We have a condo out there in Colorado where marijuana is legal, and for skiing. And there's a friend of mine who lives out there who was a property manager, and
Okay.
he was part of the EMS in this town called Crested Butte. And he tells me that, because I asked him, were there more automobile accidents, this, that, and the other thing? And he said, basically, no. The main problem that they had out in Colorado with marijuana was overdoses, not from smoking it, but from taking it by mouth. Because, and again, this is not something I have a lot of personal experience with, but if you smoke it, you get high pretty quickly. If you take it by mouth, it goes into your stomach, it has to be digested, and somebody expecting to get high more quickly, they keep taking it and taking it and taking it, and then when it all kicks in, they've got an overdose. So I kind of I wonder what your thoughts about that are, because this is.
I think that's really happening there. There's that's very well documented,
Yeah.
and the edibles, the formulation of edibles,
Yeah.
which on one hand is on one hand reduces harm, which we're glad. We don't want people to smoke drugs.
Yeah.
Smoking is bad. It's bad for the lungs, And you don't, but so edible at least is probably less harmful in that regard. But you're right, it's well documented people will overdose. I think the problem too I've read about in Colorado, and the problem that I think is, it's at this point this is happening. So the debate is more about how do we, deal with it, because it's happening whether we want it to or not. Right. It's going to happen, and we're going to have recreational use. I anticipate recreational use to be legalized everywhere. And that's going to increase access and increase the use of marijuana by everyone. Young people use it more and see it, have attitudes towards it that are like it's not that harmful. And I think we're seeing an increased use in adolescents. And that's a concern because although the gateway theory was probably propagandized, I think, to some degree and not really panned out, the earlier you expose a brain to any addicting drug increases risk. And that's a concern. So we're doing a big experiment now with our population to increase exposure to high potency marijuana, and we're going to find out what happens when you do that.
Well, I listened to a few podcasts in order to be able to ask intelligent questions when we had you on here, and the ones that I listened to, about marijuana seem to be very clear that it is in fact a gateway drug to other substances.
Yeah, I would disagree with that. I think a lot of people use marijuana who don't go to other drugs. So I think that idea is, to me, not. I don't know. We might talk about, but I think it's a concern if adolescents are using it, they're more at risk of developing problems. But the idea that I think the majority of people who use marijuana don't necessarily go to other drugs.
Well, that's encouraging. Yep. I think on those podcasts,
it's encouraging.
They were mostly.
I don't think it's necessarily good. I'm not saying, go out and smoke marijuana or use marijuana. It's okay. I don't think that's a good idea.
Okay, Gene, you look like you're ready to.
Tell us what age you're talking about early use of marijuana, because we now know that the brain's not completely developed to age 25, and most people don't understand that. They think it's maybe 18, but you're talking about.
I have kids in high school. I have kids in high school right now, and I think based on that and based on what I've read, it's the number one drug being used by our teenagers, the number one illicit drug being used, and I think. And so that's going on, when you don't want it to. You don't want brains exposed at 13 or 14 that's when they're getting exposed, and maybe even earlier in some cases. But those brains are really vulnerable, and they're using, like Mike said, edible or vaping. Vaping's a common way, a delivery device, and that's a concern. I think that's going to be a problem for some of these. That otherwise they would not have had. And, I'll say this, it's not as often, but marijuana does have a risk of psychosis associated with it. And people who develop schizophrenia, does it cause schizophrenia? I don't think that's fair, but it's associated with the first break or the first onset in schizophrenia. And we think, the one kind of question we have in psychiatry is, is marijuana going to increase the rate of psychotic disorders that we see? We don't know that. Some people say no, and we go back and forth. But marijuana is not as harmful as heroin, in my view, or other drugs, or cocaine, or even alcohol. But it's still to me something I'm concerned about, and I don't recommend and find to be again. And it's a drug that's become more like those other drugs because it's been cultivated into that, from what I can tell. But
now, one of the things that's always irritated me is why no one would change the category from category 1 down to 2 or 3 so we could do research on marijuana and find out what's good in it, what's bad, and develop medications.
Cannabinoids, cannabinoids, the discovery of the cannabinoid system was a major advance in the understanding of human biology. And, for the long time we said it couldn't be addictive because there wasn't any endogenous version of marijuana. And they discovered this compound called anandamide and then discovered the cannabinoid system. And we learned all kinds of things. We're still learning about that, right? we need to study the cannabinoid system. We need to be able to study the marijuana that is being passed around. There are, hundreds of different cannabinoids in the marijuana plant and other kinds of compounds that we don't know what they all do. And I think the ideas. One of the ideas that I've in my reading and looking at this was, the idea that sometimes they'll pay, well, this is an indica and this is a sativa, and they do this one does this and this one does that. I think a lot of that is still really, a lot of that information turns out to not be correct, and it's not reliable information, and we still really don't know what these different strains are really doing in any kind of reliable way, despite what somebody at a dispensary might say or claim. I don't think they can claim, oh yeah, it does this. But we need to be able to do more research on that. I think CBD, there has been a lot of research on that, and that's been encouraging and interesting, that they might have some benefit. I mean, but again, how much benefit? I think it's quite, the jury's out on that.
Well, let's
So
change.
if we change the category of marijuana, could we go ahead and do that research?
I think it would make it easier to do, yes. And I think there's a lot of consensus that really needs to happen. And I don't know what the opposition to it really is, honestly, other than maybe law enforcement concerns. But I don't know. I'm not informed enough to know why there's an opposition to that or why it hasn't happened already. But this is working out. This system that we have right now is there's a lot of money being made right now from the current way it's being done.
Well, let me ask you a question about the recovery process.
Okay.
Now, my understanding that this is a multiple stage process, and I wonder if you could kind of give us and our listeners kind of an overview of and I'm not exactly sure if this is a fair question or even how you would answer it, but I'm going to ask you the question anyway. So, you've got kind of group therapy, you've got individual therapy, you've got medications, and I know with each drug and with the mental health issues, there's going to be a whole bunch of different changes. But could you sort of kind of give us a broad overview of how these different components of the recovery process, would work? For instance, does group therapy, is that something that it works for everybody? Or are there some individuals are more receptive to it than others, as opposed to doing an individual, kind of therapy, or again, as opposed to maybe having some medication, or maybe part of one and, part. Do you understand the question I'm asking? And I know it's probably a difficult one to answer, but I was hoping you could maybe give our listeners
an overview of the recovery process.
Yes,
and
yes. And maybe,
how you assess somebody.
Put in what things maybe work a little better for what situation.
Right. So I think one of the advances in assessment and evaluation of addiction that has been something that's been more incorporated into what we do now is when we assess somebody who comes into treatment, either outpatient or whatever they come into the hospital. In the addiction field, it certainly became, there was more attention to what's the appropriate level of care for this. What level should they enter? Should they be outpatient? Should they be inpatient? Should they go to residential? And based on severity and based on where the person was at the stages of change, that would be part of the assessment. And patients who need to be, for example, need a medical detox, or who have more risk of imminent death, or somebody at high risk of overdose, for example, might need to be treated at a high level of care. That was a change where it was just one size fits all. Everybody does this. In the past, there became more of a consciousness around, let's figure out what the best level of care would be. A lot of times patients don't want to do that. So then, we're back to square one where what they're willing to do, and we try to meet them where they are. And now we would try to reduce harm. If somebody comes into treatment, and let's say they go into a treatment program where they get on medicine and they quit using, we know that their brain's going to go through some early stage changes. They're going to start recovering. They're going to start feeling feelings. They're going to start having, what's happened to them is their ability to enjoy things has been diminished by their drug use. And we call that anhedonia. That gradually improves with time with maintaining abstinence from the drug, and people will develop more of a normal reward function as they've maintained time in recovery. And if people reach a certain milestone, it makes a big difference in their chances of maintaining recovery, maintaining abstinence in cases. Like, for example, alcohol, this has been really looked at extensively by the NIAAA and how the brain heals over time after it's healed from abstinence. And there's a number of things in place to help people maintain abstinence. So like 12-step recovery is talked about a lot and it gets some controversy, but again, it's been extremely helpful and important in the destigmatizing of addiction and understanding it as a disease. And then, yeah, we do use a lot of evidence-based therapies like cognitive behavior therapy, and group therapy is an evidence-based therapy for addiction. But that doesn't mean it's the only one. Some people, aren't appropriate for group for different reasons. But we use a lot of group and addiction treatment because that's a good way to help with dealing with the shame and stigma of the disease. A lot of people with addiction feel full of shame and feel humiliated, and like I said, they're traumatized. And so part of the treatment is about dealing with the shame and helping to reduce that, or and so the best way to do that is to be in a room of other people and share the experience and realize, this is a disease, and I'm not alone in suffering from this. That's a big part of the treatment. And patients who remain really ashamed, I think, are at higher risk of relapse. So we really try to address that in recovery.
Okay, one quick warning. We've got about 5 or 6 minutes left.
Okay.
So I just want to be sure we
It's your time. I'm charging you guys about an hour, so you guys
we keep that
figure
in
however
mind.
you want to use your minutes.
Well, let me ask you a question. We got into this stuff earlier a little bit with the Medicaid thing. As you know, this program is sponsored by Kentuckians for Single Payer, and we're promoting Medicare for All, as you heard from Paul's opening remarks.
Uh-huh.
Suppose we had a Medicare for all in this country. How would that affect, in your opinion, your ability to treat the issues you deal with? I mean, I'm assuming it would increase access. Would it make that much difference?
It'd have to be different than the Medicare we have now, because the way we have Medicare now, there's still some restrictions to addiction treatment in Medicaid. Like Medicaid actually, pays better for a lot. So that may be a technicality.
Well, that's interesting. I didn't know that. Yeah.
I think that we had Medicaid Medicaid pays for a lot of the treatment now. And so I think Medicare tends to reimburse a little lower. But I don't. So I'm not an expert on what Medicare pays and doesn't. But to me, the idea of having universal coverage and having everybody have the same coverage and people having coverage for addiction treatment, that to me that would be what we would want. We would want everybody to have access for addiction treatment. We would want it to be quality treatment. We want it to be reliable. We want it to be something that people access. Most people with substance use, even to this day, don't access treatment. They do not. They either deal with it themselves or some other way, and it's still. And we've got a huge infrastructure that we, have put a lot of time and money in building, but still, most patients don't access it. So I think if we had more of a universal healthcare system that was part of our system, then I think we would have better utilization, and we would have people who would be not as, reluctant. I think if you had a system where that's what we did, we treat addiction, it's part of what we treat, like everything else, we cover it, then I think that reduces stigma. It helps with skill and knowledge and people being good at this, and it improves over time, right? That's what you get when you have a system in place that's reliable. And again, part of the disease of addiction has been patients have been, raised in families where they were there was chaos and crisis, and and so one of the treatments for people was being reliable, having a what we call structure. Structure is really important to treat addiction. So that would help provide a structure that would be reliable and would be there. And rather than what we have now, which is a lot of uncertainty, patients don't know if something's going to be authorized or not. Do they have coverage? Do they not? How much are they going to have to pay? Stresses people out and makes them sort of want to just avoid the whole thing, right? If we didn't have that, it'd be better.
All right, Gene, one last question, and we're about ready to wrap this baby up.
What about people who get off addiction on their own? I've seen lots of patients in the past who said that they drank quite a bit. By quite a bit, I'm talking about at least a case of beer a day. And they said they just decided one day they were going to stop. And I've seen patients who were taking narcotics for back pain, and they didn't feel good, and they just stopped on their own. Or they'll say, I had experience with Jesus and was saved, and I stopped, and I haven't drank or used drugs in the last 10 years.
Yeah, that happens. And that's not something to, but patients do get better, and sometimes from other illnesses too. But I think that really happens, and I think that's great. And I think people should be encouraged to try. Most of the time when I'm seeing patients, they've already tried all those things, and they have failed. So I see the patients who fail, but, I think a lot of people do find church, and you see this in the literature, in the 12-step recovery literature too, that people would go, I think that's totally fine. And patients who quit on their own after having a serious problem, that does happen. I don't think those patients, if you can do that, you don't need to necessarily go see somebody or seek help. You still might want to think about it. There might be some other issues there, but that's great. You don't need my help.
That's great. That's. I think we're going to have to end on that. That's a very
Thank
positive.
you guys for having me.
Chris,
really enjoyed talking to you guys, man. It's a lot of fun.
Thank you very much, and we appreciate you coming on. And I think our listeners are going to learn a lot about this important issue. So, Paul, you want to take us out?
Yeah, I want to thank you again for coming in and talking with us today, and I've learned a whole lot. And I hope our listeners have too. This is a very important topic. We could probably easily do another hour program if Chris is amiable to it at some point.
We'll have to see what happens, right? Like, I may not be allowed on after this.
Well, anyway, and I want to thank our listeners for tuning in, because without you guys, we wouldn't have a program. So I just invite you to tune in the next time for Single Payer Radio. Have a nice, wonderful rest of your day. Ho, ho, ho. This is Paul Hoppy with Forward Radio, bringing you the gift of community radio all year long. As we gather for the holidays, we're asking for your help to keep the spirit of independent radio alive. Just $4 a day keeps the lights on, the voices strong, and the music merry and bright. So stuff our stocking with your generous holiday donation at forwardradio.org, where the sound of the season stays local, lively, and full of cheer.